Physician practicing in Ferguson, Laura, full scope family practice, which is really exciting and often unusual in our context. An amazing clinician, and I've had the pleasure of being her mentor for her CSP program, which has been such a delight because she's so competent, thoughtful, and I've really been able to watch her grow in her research capacity. She is doing a grant generating project through NACRAG. She now has a PSI fellowship for 2 years, which is incredible. So she has been one of the scholars who actually kind of follows that path and gets on the launch pad and goes forward with the research career. So I'm really excited to hear about what she's been doing and to have you guys here.
Great, thank you.
And when you're famous, we can say we knew you first.
We knew my way.
That's right.
That's so true. Is the video okay? Are we?
Yes,
okay.
we are good to go.
I can't see the video, so I'm just going to trust that everything is fine. And if it's not, let me know. Or if I need to speak up or down or do anything crazy, just let me know, because this is a bit new for me to be speaking, but also speaking to everybody. So I hope that it works out okay. I'm just going to pull this a little closer. I've stolen your plant stand from the hallway to have my notes on. So, okay, so pregnancy after stillbirth, an international qualitative analysis of the patient experience. So this is who I am. I'm just going to I kind of was going to introduce myself. Usually I give a lot of talks, or a fair number of talks that are clinical talks that are about different clinical topics, family medicine topics. And we always have a disclosure slide at the beginning saying we have no conflicts. And when I was taking that out of this talk, I thought, well, maybe I'll leave it in just to explain who I am and where I'm coming from. Because as Claire said, I'm a little bit different than a lot of you guys. So basically, I am a community family physician, and I work over in Elora and Fergus, which is about an hour west of Toronto. In total, I am in a FO, which is we're about 30 split out between 3 small towns. 30 sounds like a lot, but we all work out of the hospital as well. In fact, it's a requirement of our FO that we have hospital privileges. So we all do emerge, OB, anesthesia. We all follow our own inpatients. We do a combination of those things, that's kind of how we work. So everyone has somewhat smaller practices than might be if you were just urban-based, and that's kind of how we work. So I personally do obstetrics as well as my inpatients plus clinic. Then through Bill, who I will forever be indebted to, because he really was the one that got me on this path. Some days I regret that, but most days I'm very happy with him. I am a clinician scholar. I've been doing that program part-time over 2 years, and that will wind up at the end of September of this year. Then I'm also, my clinical appointment is through McMaster, because that's our closest teaching center. So we get clerks, and we actually get about almost 200 learners through our community a year. So we have quite a few coming through, medical learners. There's others that come through, and then I'm also doing a master's in epidemiology at MAC. So that's been the bulk of my clinician scholar years, is working on the master's. And I finished my coursework now, and I'm just writing my thesis. And this presentation today is one chapter of my thesis, which will be 2 chapters. And then I have this grant generating project thing as well that I'm doing, which is a 1-year program through NACRAG, which is a great program that I really encourage people to apply to if you're interested at all. And it helps, I'm also using this project for that, and it helps you end up with a proposal to apply for a big grant that you could actually use in real life. And then I was able to apply and get a Janus grant through CCFP, which I also encourage people to apply for because they're actually not that hard to get. And then I also got this PSI grant, and I added that up just to say that so I have no funding as a researcher per se, but there is money. Like, there is actually money out there for community researchers, and I think it's really nice to see that there is support if you look for it, that you don't have to just do this 100% off the side of your desk, that there's support for it if you look for it. So. Okay, so on to the actual project. So my goals for today, this is my bar to sort of show where I am so that everybody can keep paying attention. To me, this is a research in progress round. I'd love feedback on my content and methods. I don't actually have results yet, so if you're interested in results, I apologize for that. I'm not there yet. Feedback on the presentation itself. As I say, I do a lot of clinical presentations, but not so much research, so that would be really helpful. And any ideas, obviously, for collaboration or moving forward. That's sort of what I'm looking to get out of this today. So I'm just going to talk about language at the beginning. As stillbirth is something that always then brings up babies, but are we calling them babies? Are they fetuses? What are they exactly? So my caveat is that clinically, I always follow the patient. So if a patient is using the word baby, I will also use the word baby. As we know medically, initially we've got this zygote, and then we have it's considered an embryo up to about 8 weeks, and then after that it's considered a fetus up until a first breath is taken. In a stillbirth, no breath is taken, and so there's some disagreement by very philosophical people sometimes about baby versus fetus. Regardless, I will always, whether it's a woman who has a pregnancy she absolutely does not want and is sticking with fetus, whether it's a woman with a 26-weeker who is in early labor, this is her baby, I will always follow the language of the patient. You'll notice that through this presentation too, that I switch back and forth and will often use the word baby when I'm talking about stillbirths, and I'm completely comfortable with that, and I always encourage clinicians to do that too, and as a researcher I stay with that very strongly. So that's language. Pregnancy loss, just definition. So it is an embryonic or fetal death. Miscarriage or abortion, as you know, medically we use the words interchangeably. Considered loss of pregnancy before 20 weeks. Stillbirth is considered after 20 weeks or 28. So there's kind of this in between where when we think of, in Ontario, you have to register a stillbirth after 20 weeks. So it's considered a stillbirth, you fill out a different certificate, and you have to bury the remains, you have to bury a body after 20 weeks. Before 20 weeks you don't, if that's considered not something that is in any way viable or registerable, and so you don't. After 20 weeks you do. The WHO is starting to make another line around 28 weeks afterwards, which are more considered, we wouldn't call them term stillbirths, but at least they're more like baby stillbirths. The reason for that is that they notice there's a surge in the numbers of stillbirths, especially in some developing countries, as our prenatal screening numbers increased and our ability to find genetic defects while in utero increased, and people were terminating pregnancies after 20 weeks, and those were getting counted in as stillbirths. So the WHO has made an effort to go past 28 weeks. In the research literature, you just have to be careful what you're talking about when you say stillbirth, whether it's 20 and beyond or 28 and beyond. So that's some definitions there. And officially, a stillbirth is when a baby is born, no breaths at birth, and the APGARs are recorded 0 and 0. Nationally in Canada, just so you know, we have about 400,000 births a year. Stillbirth rates vary between 3 and 5.5. So if you count 20 weeks and up, it's closer to 5.5. If you count 28 and up, it's closer to about 3. So in Ontario, where we have about just under a third of those births, that translates to between 3 and 4 stillbirths per day in the province. So it's actually kind of a lot, right? Like that's more than you would think. This is an impact. It's not something that just happens and when you're in your own little maternity unit, you don't necessarily notice it as much, especially if you're not in a teaching center. But 3 to 4 is actually a lot. It's a big, and that number has not budged much as many other numbers in maternal research have changed in Canada. So preterm births have changed, the numbers, preterm survival rates have changed. Lots of other parameters we look at in maternal maternal numbers have changed. This has basically stayed static for a long time now. And so that's important to think about, and it's something that really affects your whole sort of life when it does happen to you for a number of reasons. It happens at a time in your life when you're not, you're young, everyone around you is pregnant, you're not really expecting this thing to happen. And when we look at the literature on families who experience term stillbirth, there's lots in terms of their grief and their shock, even PTSD type symptoms. They feel like they're losing part of themselves. And there is a fair bit of literature on how to handle the actual stillbirth itself, the day of, the moment of, the week of, and then help families through the immediate aftermath. And then and a little bit starting to come out in the distant future, like what does a family look like 10 years after stillbirth? There's a reasonable amount of literature that started around that. But my interest has sort of become the pregnancy after the stillbirth. So many families who have had a stillbirth will go on to become pregnant again. That number is not actually collected well in Canada. It's hard to pick that out. And I'm actually working on a small side project where we're trying to look at that. and see exactly what our numbers are for who has a stillbirth and then goes on to have another pregnancy. But anecdotally, from the qualitative research done, we know that many families will become pregnant again, and often within 2 years. Within 1 to 2 years, they'll continue on with their family. These pregnancies are really fraught with anxiety. They do have about up to 5 times risk of another stillbirth in that pregnancy. And sometimes that's because of identified reason, and sometimes it's just random. Often we don't know what the index stillbirth cause was, and we just know that that next pregnancy is at a highly increased risk, which, as you can imagine, does not make it a very relaxing pregnancy. Internationally, there are actually very clear guidelines on what excellent care in that pregnancy should look like, either medically or psychosocially. There's been some research done, but that's the gap that I'm interested in, is what should care in the subsequent pregnancy after stillbirth look like. So these are, having said there's no good guidelines, these are guidelines. These are hot off the press, actually. They just were published in the SOGC, the Canadian Journal of Obstetrics and Gynecology, last month. I was part of the committee that put these together. And they're good. They're very, they're great. But even they don't have a lot of depth, especially in terms of the emotional support that we should be offering. It's kind of the usual, get in there, talk to them, offer extra support, but there isn't a lot in terms of what do families actually need and what is helpful. And we know that in other areas of maternity care, there is very specific support that can be offered that actually improves outcomes in terms of even hard outcomes. So there's a group that will offer pregnancy circles for low-income moms, and that actually will decrease their rate of preterm birth, increase their rate of breastfeeding, just offering that kind of group social support. And there's other studies through maternity care that show that, but there's nothing around stillbirth, and specifically what should be done around stillbirth. And so one of my hypotheses is that there's a gap there, and that there is opportunity to actually potentially decrease stillbirth by providing really excellent care in a subsequent pregnancy. So my research question is, what are the most important aspects of patient-centered care during subsequent pregnancies among families who've experienced stillbirth? Fair enough? That's my research question. So families who've experienced stillbirth, what are the most important aspects of patient-centered care during their subsequent pregnancies? So study design, basically this is, I was going to say something else about that. I'm going to back up, sorry. Interestingly, I'll just throw this in. When I'm doing the lit search for this, it's really interesting because, in fact, stillbirth is often considered an exclusion factor for maternity studies. So there'll be this great study around what kind of support do women want in pregnancy. Oh, but we excluded anyone who'd had a previous stillbirth because that might be a confounding factor, right? So in fact, or they'll say there was a previous pregnancy, but it's not specified whether that pregnancy ended in a live birth or not. So trying to tease out what's out there in terms of literature is surprisingly tricky because stillbirths are often excluded or not drawn on as an actual useful thing to include in your research population, which I think is a big gap. There are a few clinics that offer specialized care. Yep. We have a question from the crowd.
Can we interrupt?
Yeah, for sure.
So when you say the most important aspects,
yes,
you mean, I take it you mean from the perspective of the patient.
Yes.
I guess that's what it says, right? When you say it's aspects of, I just wonder if your research question wouldn't be more clear if it was explicit that it was from the perspective of the
patient. Yep.
I mean, I guess you're implying that when you say patient-centered care, but
the needs. What are the most important needs?
It's because often then you talk about families.
Right. Yeah. So it's not quite clear who. Yeah.
Simply, what do families perceive as the most important aspect?
Right. Yep.
part of what made me stop at this point was I was thinking how valuable it would be for the woman to be cared for by the same family doctor that she knew and had a relationship with. On the other hand, It's also very difficult for the family doctor if the patient had a stillbirth under their care.
Their care, yes.
So,
Right, so the perspective of the family versus the perspective of the clinician.
yeah.
Right, right.
But anyway, this is about the family.
This is about the family.
Okay.
Yes,
It's not just the patient, it's the family.
it is the family, yes.
Yeah,
Yeah.
so I would tweak that a little bit.
Yeah, make it a bit more clear. Okay.
So I had a question about the statistics earlier. Are you including women or families that have had pregnancies, like live birth pregnancies, and then stillbirth, and then another, or is it just families who had their first pregnancy was stillbirth, and then they had
Do you mean for the statistics, the Canadian-wide statistics, or like what's in those statistics, or do you mean for this
I was wondering if
question?
you knew the numbers. No, not from this perspective. It was with respect to the data that you showed before. So I was
Yeah.
just wondering if there's if you're looking at women who their first pregnancy was stillbirth and then they had.
So the Canadian and Ontario stats that I showed are for any stillbirth.
Mhm.
So there might have even been some that happened to the same woman, although it's per year, so it's unlikely you'd have 2 in 1 year. This research project is specifically looking at women who have had a pregnancy, have had a stillbirth, and are now, what do we do with their subsequent pregnancy after their stillbirth? Does that answer your question?
Would they have had like a live birth pregnancy before?
Not necessarily.
No?
They might have, or they might not have.
Okay.
Yeah. Does that answer your question?
Yeah, I'm just wondering if you expect to see differences between the women who their first pregnancy was
Mhm.
live birth versus the ones
Live
where their
birth,
first.
stillbirth, live birth
Right.
versus just first stillbirth and then live
Yeah,
birth.
yeah.
Yeah, sure, it's a good question. I know. Yeah, no, it's a good question. I don't know that I may be able. Yeah, it's a good question. We'll get a little more into that as we go on to see what I'm actually doing. Yeah. Okay, so there are a few existing clinics that offer specific care to women who've experienced stillbirth or now another pregnancy. There's one in Toronto, there's one in Manchester, England. They're starting one in New Zealand as well. Obviously, they're very localized and very specific to their urban center. And so my question becomes, if we could take that and scale it out, especially to rural areas like where I live, what would that look like? What would need to be in it that would work and be key to how those programs would work? That's where my question comes from. Does that make sense? Okay. Good. Getting the slow nod from Bill. Okay, I'll keep going. So study design. So what this is, what I'm actually going to do is a retrospective analysis of a cross-sectional survey. This is secondary data. It's already been collected. And what happened was that a few years ago, a big international stillbirth research group did a big survey. This is a survey. Oops, okay, it doesn't actually have it on here. Sorry, I'm going to back up. They surveyed across 40 countries in 8 different languages. So it was a huge number. And it was all about different stillbirth. It was geared at women who had families who had a stillbirth, regardless of when, where, what. There was a subsection of it that opened up when they asked you, have you had a pregnancy since your stillbirth? If you clicked yes to that, a subset opened up, and then there was a series of questions. Some of them were quantitative, how did it go, 0 to 10, etc. And then there were 3 qualitative questions that were answered. So as I say, subset of stillbirth, that was your qualitative experience. It was web-based. The recruitment was through National Stillbirth Association's online groups, word of mouth, and social media. And they got, for this particular subset of yes, I've had a pregnancy after my stillbirth and I will answer this question, there's almost 3,000 responses from 40 different countries in 6 languages. So it's quite a solid set of data. The questions were 3 questions, and the first one was thinking about the care you received in the pregnancy after your baby was stillborn. What were the most important things to you? The second one is, are there ways your care could have improved in the pregnancy after your baby was stillborn? And the third thing was, is there anything else you would like to tell us about the pregnancy after your baby was stillborn? So very open-ended, very general, but designed specifically to elicit answers that went beyond the quantitative questions that had just been asked. So the quantitative part of that subset has been published already, and this is it. So it's care and subsequent pregnancies following stillbirth, but they just pulled out the first answers to those and published that, and the qualitative answers to those 3 questions have not yet been analyzed, and that's what I'm going to do. That's my project. So, any questions about that so far? Am I doing okay?
40 countries?
Pardon me?
You're doing the 40 countries?
Well, yes, that's my plan eventually. I'm going to pull out Canada first, and take a quick look at the Canadian data. I think there's 58 Canadian responses. So I'll pull those out first, take a look, that's our plan, and then sort of see what happens after that. We might just then do English-speaking countries first, and then sort of see, and see if we're getting redundancy. There will be some translation issues, etc. So yeah, it's could be turned into quite a large project. But for the purpose of the thesis, I'm at least going to do the Canadian responses, and maybe a little bit more than that, depending on what it looks like. I haven't actually received this data yet. It's still housed in Australia, but we've just gotten approval for it to be released for sure 2 weeks ago. So it is coming. It's really coming, which is good.
Is there a cost?
No, not so far. Part of the mandate of doing the original survey was that it be internationally available and used. And they wanted it analyzed in different countries, and there hasn't been a Canadian-based analysis yet of this survey. So they're actually pretty excited that someone is going to do it from Canada. There's been a lot of European ones and a lot of in Australia and New Zealand, but no one from Canada yet. Although Canada was on the original ethics approval, there was a UBC researcher that was involved in designing the survey. So it went through UBC ethics at that time, but that UBC person has not made use of any of the data yet. So yeah, so that's a project. Okay, so qualitative data analysis, sorry, I'm just going to keep an eye on my time. Allows themes to arise from data, allows the patient experience to remain central to findings, keeps the finding close to the data, and allows data to stay rich. So this is perfect choice for this type of data because it's something where I really want the patient's answers to speak, and I'm going to I'm not looking to impose, well, I think they probably need, a half-hour counseling session at their first appointment and then maybe a phone call every 2 weeks, and what do you guys think of that? That's not what this is. This is reading their answers and pulling out themes and pulling out the data and keeping it close to what they're actually saying. Data analysis, social constructivist approach, what the heck is that, right? So all those in your qualitative theory methods classes, but it's very simple. So basically means just what I said. I'm looking for multiple meetings of events from the participants. So I'm looking for them to generate ideas about what quality care should look like, rather than verifying what I think good care should look like. That's all that means is constructivist is allowing the data to construct what their reality is rather than me looking to validate some hypothesis that I've come up with. Data will all use NVivo 12, an inductive thematic analysis, which is kind of saying the same thing, but basically I look for themes from the words and you keep going. That's the inductive part of it. So I'm using the data itself to generate some themes. And then as I work through it, it's an open coding framework, so I can make the codes be whatever I think they should be as we go. Start narrow, so lots of themes initially, and then starting to regroup them into broader categories as you go. Right? Very practical. It's actually what we do every day as family doctors, but it's a constant comparative method, so it means as I'm extracting data or highlighting or coming up with a new code, I'm always looking back to think, oh, maybe that's kind of similar to what I did a few paragraphs ago. Interesting, maybe that's going to turn out to be a bigger theme. You're constantly comparing back to what you've just done, rather than filing everything under categories that you've predetermined. Translation is a big issue. Which I'm kind of ignoring for now until I actually get it and see what it looks like. But that will be, I'm just going to ignore that for now. we'll move on. This is what in vivo actually looks like for anyone who's never seen it. And so basically you select little pieces and then you make a code, and then you can group it later into this is what Betty said and this is what Maria said, and these are areas where they overlapped, and then these are areas where they look a bit different, and you can keep generating these and going back and looking and grouping things more and more until you end up with broad themes that, and then you're also looking for outliers that, wow, a couple of Bettys really thought this was important, but the Marias never said that. That's interesting. And you can sort of keep working that way and grouping things in that manner. Yes, Bill?
I think this is absolutely the right methodology for this research question.
Thank you.
My question is, you're in a clinical epidemiology master's program.
Yes, I am.
Did you get any pushback for choosing a non-quantitative approach? And I mean, do they offer courses in this?
Yep, they do actually. So it's a little sidestep to that. So my master's is actually, because I live where I live, my master's is actually through the University of Guelph, which is a vet school, not a med school. And so my epidemiology is under population medicine, which is it's the vet college. Like it's actually, so my classes are about half veterinary students. There's lots of human students, as students doing human work. But literally when I submit things for them, I have to add in stillbirth, human stillbirth. I have to specify, like it's not sheep or bovine, which also have big issues with stillbirth, it turns out. And then when I submit something for the rest of the world, I have to search and pull out the human, because it looks really stupid if you're applying to, and you're saying human stillbirth. So the reason I say that is that you're correct. And because of that, especially, I think they are very quantitative oriented, because you've got 3,000 cows, you just vaccinate them and then study them. You don't have to spend all the time asking the cows, how do you feel about that vaccination? And is it okay? And can I also vaccinate your calf? You just do it. But they're really working on increasing their qualitative side. So in fact, they're really excited to have students coming in who want to do qualitative. They did offer a full course in qualitative research, which I kind of learned, although it was only a one semester course, in my opinion, looking at other universities' qualitative courses, I think it was more like two shoved together, because they don't have the depth to realize that it could actually be spread over 2 classes. Do you know what I mean? So they kind of took everything and shoved it at us in one semester. And it's rumored to be this very overwhelming course, but I think that's why, because it should actually be 2 courses, but it's put into one. And I did that, and as part of that, we actually did all this reading. I did my own focus group. I ran 3 focus groups, collated it all, transcripted it, coded it, and came up with a full paper at the end of it in that one semester. And so I feel like I have enough of a depth, and at least you never have enough of a depth, do you? But I'm there to do this, I think, and I have good support. Yeah. Does that answer your question?
Yeah.
Okay. Okay, limitations. So I do want to spend a little bit of time on this because I think it's important, but I won't. So basically, there's certainly a good literature out there to say, what do you mean you're doing a questionnaire? That sounds quantitative. Qualitative research should be focus groups. It should be interviews. You can't just sort of say anything else on the end of a quantitative survey and consider that to be qualitative research. That is not adequate, which I totally respect, and I think that can be true. However, I think that there are strengths for the way this has been done. I think the most obvious thing is the scope, right? Like you can't do focus groups across 40 countries with 3,000 people, or at least I couldn't. That would not be functional. So the scope is really amazing. I think there's maybe something to written versus spoken language when it comes to translating, but I haven't really explored the literature much on that. So it's just kind of in the back of my head that it's kind of, it's going to be different, and I'm not convinced it's different in a bad way to translate written answers versus listening to someone talk for an hour and translate what they're talking about. So I'll just leave that as an aside, although I'm curious if anyone has any opinions on that. Anonymity, and I think when you're, this is a really heavy area. It's a very personal event to have happened to you, and I think there's some strength in being able to just sit alone on your couch with a computer and write, instead of being in a big group with people where you're talking about your baby who died, and you can take your time with it, you can go back to it. You're not talking to a physician because maybe you think that there were errors made or that you weren't treated very well by your physicians, and now you're talking to another physician, and that's a bit awkward, and there's literature about that too, but when a physician, because I'm not just another epi student, I'm actually a practicing physician as well, and I do OB, and I think that for me to conduct interviews with patients is different than a student coming in who has a different background than what I have. So for all of these reasons, I think that there is strength to the way that this data has been collected. That can be argued forever, but that's my personal opinion. There is good literature to say that even within the context of a questionnaire, that it can be well done. You can do good qualitative research with a questionnaire, especially if your questions are well thought out. So it's not just anything else to say, but you've really put some effort into how do I phrase this and how do I elicit the information I want. It's designed as qualitative from the start, which was the intention of this survey. It was written that way, and that the analysis is robust and done separately. And I think this is kind of ideal where someone else has already done. I'm not even looking at the quantitative. I mean, I read the paper, but I really didn't, I didn't do it, and I certainly didn't immerse myself in those numbers at all. I'm doing this, and I'm going to do my robust qualitative analysis, and it's separate from what was done earlier in the questionnaire. Going forward, once the data is received, as we already talked about, I may pull out some of it and break it up a bit. And then this picture represents that, my ultimate goal eventually is the care of women, especially in rural areas and subsequent pregnancies, and what can be done for, the 3 women in my town who have had a stillbirth versus the 300 women in Toronto who've had a previous stillbirth. How do you face those 3? How do you treat them? What do you do? How do you care for them as excellently as ones who are down the street from a specialized clinic? And I think it's essential that we figure out how to do that. And I think that that's kind of my underlying goal. And I think, knowledge translation, so all the usual things. There's lots of ways to spread this work around, and that's a big goal of mine. The GGP Fellowship obviously is a big part of that, and that, Craig, social media, etc. And that's all I have to say for now. So questions and comments. How am I doing? That clock is completely... I think you had your hand up first. Yes.
Thank you for a very fascinating talk.
Thank you.
I enjoyed that. I tend to always ask this question. What motivated you to engage in this study?
Yeah. So the question is, the people here on the probably, so my question is motivation. So, I've done OB for probably 10 or 12 years now. And so I didn't do it when I first graduated. And I realized quickly that when there was a stillbirth, I wasn't afraid of it. And so for whatever strange reason of my life, a dead baby does not freak me out, to put it bluntly, in a way that it does very much freak out some other caregivers. And I just kind of rose to that. I mean, it's funny, when you're in a small town, you sort of become it's that weird lesion. So-and-so saw a lesion like that, call him. Oh, this is a stillbirth. So-and-so's good with stillbirth, call her. So I would start getting called in for issues or for when there were late losses, and my interest just grew from that. I found I was very comfortable in the room. I had a number in a row when I first started, and so it just kind of grew from that, to be honest. Yeah, I haven't had my own stillbirth. It's not an experience I've had, although many in the research community have, which makes it really interesting to be in a room. They have an international conference every year, and you go there, and probably 3/4 of the clinicians have had their own stillbirths, and that's why they're in the field. And it makes it a very powerful kind of research meeting. It's different than going to diabetes research day where we're all just kind of there to get the pearls. It's a very, it's a bit of a different crowd, which I really appreciate, and it's really a neat crowd to be part of.
Yeah, thank you. Such an interesting topic. I'm wondering if there would be any way to disaggregate the data and see, for instance, what new Canadians say versus what a second or third generation Canadian says, or Indigenous Canadians compared to non-Indigenous Canadians.
Yeah. I don't know yet. It's a really good question. I've had many fantasies, I would almost call them, about what could be done, but I don't know yet. I don't know the answer to that. It's a really good question. I suspect, I don't think the Canadian numbers would be high enough for that. And so, I haven't seen the national breakdown yet for other countries. So I know Canada really lags in stillbirth awareness and research. So there will be very large numbers coming from Australia, UK, and some of the European countries where they're far ahead of us in terms of both clinically actually and research-wise. So so I'm just gonna have to wait and see. Yeah.
I would just add to that it's not just the Canadian population, but you're asking about patient perception. We know from performance measurement that satisfaction is context dependent.
Yes.
You can be very satisfied, or you could expect certain outcomes if you see rates that are 3 times higher. Or so looking at international comparisons, if you can tease out what the baseline context, whether that actually changes people's expectations and perceptions.
Yes, that's a really good point.
And I don't know if you'd see enough variation that
that's something
it would impact it.
Yeah, okay. I think health system will make a big, I'm assuming healthcare system will make a big difference too in terms of, so I think the most useful ones for the thesis, if the Canadian data is not enough, I'm assuming I would then look to New Zealand, Australia, and England and UK, right? Like those are the common. I don't want to do the American data. It's very, very different situation from here in terms of stillbirth.
I was even thinking developing world.
For sure, absolutely, that's a whole different level. Yes, yeah. Sorry, Simone technically had her hand up. Simone, we're done.
Thank you. So I thought it was an excellent presentation and very thoughtful. Good on you. Like you've really thought this through. I have a question in relating the data that you have to the question. And so it's the perception or the needs of the families. But is the questionnaire answered by the women?
It could have been answered. Generally, it was either parent, so it could be dads as well.
Okay.
Yes. Yeah. There wouldn't be children answering, like siblings. There has been research into that, but that's totally separate from this. But it would be both. And I think where you're heading is, should I just say women and stick to that?
Depends. The portion is just.
Yeah, I almost have to see the answers first to see, but I've kept it as families for now because officially, when the questionnaire was put out, it was available to anyone and any adult who and either parents. Let's put it that way. Yes.
Yeah, great, Sarah. Thank you very much. Terrific presentation. Just had a couple of comments just around around the limitations first of all, and then around the analysis when you get to this stage.
Yep.
The first one, around the limitations, as you pointed out, often with questionnaires, right? They just say anything else or anything that we've missed or
Yes. Yeah.
And there's actually a good paper that was out last year, I think either in academic medicine or medical education. It's written by Corey LaDonna here at Ottawa.
The Ottawa paper, yes.
And Lorelei Lingard at Western.
Yeah.
That's right. That one can actually help you, like when you sort of justify, right?
Yes.
Using this data, right? Because you're not, because you're not doing interviews or focus groups or observations or more of these traditional qualitative means.
Yes.
So that's one piece, and then the second one is qualitative researchers don't use the terms validity and reliability, right? But certainly legitimization and trustworthiness, these are important aspects. All right, and there are certain things that you want to ensure that you're doing to show that your analysis of this data is going to be trustworthy, right? Because right now it's you looking at the data, right? You're one person, right? So one means of doing this is having someone else, doing this with you, whether it's your supervisor or whether it's it's a colleague. That's one means, just so that you can see that you're sort of on the right path, or you're thinking, or if you are having some divergent thinking, you work that out. Right? Right? A strength, as you noted, was certainly yourself, and you need to bring that out, because in qualitative research, that is a strength, right? You need to identify that because it's very subjective, right? So it's important that you bring that that's
That
good.
makes sense.
Now, the other thing is, another means is around member checking, right? So when you do interviews, you may give a summary of what your findings are, you know, to those that you interviewed. Say, you know, does this make
Right.
sense? Now, with
Yes,
a survey,
yes.
you can't necessarily do that.
Mhm.
But maybe there's others in your community that have expertise
Yes.
that you do too, where you can send your summary to them and say, you know, does this kind of
Sound.
fit? Does
Yeah.
this work?
Yeah.
Right? Or maybe actually to those that may have had stillbirths
Yes,
as well, to say,
yes.
does this resonate?
Yes.
You know, does this matter?
Well, and often certainly in program development, this would be kind of a first step or a second step, you know, maybe after a needs assessment plus a scope and review or a lit review, and then the results of this would go to focus groups or go to, right? And so that part of it could definitely, whether or not it's actually part of this chapter or not is, yes, that's a really good,
Do you plan to have a second person?
We've talked about it, yes, and I said my other chapter is actually a scoping review, and I have a second student who's doing that who's being my second person for that, so it's certainly possible, yeah.
So guys, we don't really need to go.
We
into
do
it.
have some questions.
But there's
in
a
the chat.
lot of questions.
Oh, really?
Yes.
Oh, amazing, okay.
Yeah, so-
yeah, totally, I
so-
can't see them, sorry.
Yeah, that's okay.
Yeah.
So Dr. Claire Liddy has two questions for you.
Okay.
So the first one is she agrees with you that, you know, the strength of the study is definitely the scope,
Okay.
the scope of the data that's available, and she's wondering with the research gap that's also there, would you think of doing a PhD because there is potential. There is. She believes it's doctoral material.
Thank you.
And that's the
anyway.
first one. And
I
I'll let you answer
appreciate
that,
the
and
vote
then
of
I'll give you.
confidence, yes.
I'll let you answer that one, and then I'll get to
Okay.
the second one.
So I currently no, but I know where you are, and I think I don't know. It's still under review, but I don't think so. I feel like I can do this as a clinician instead, and I think a PhD is a bit too much of a vortex for me right now at this stage of my career, but we'll see. Thank you.
And then the second one is, have you considered including patients with lived experience on your qualitative analysis?
Right, and so that would be including patients with lived experience in my qualitative. Oh, I wish you were here to talk about that more. You should email me with what you mean. I think certainly what we just talked about in terms of taking it forward to focus groups or running it by people. I have a wealth of people who I can use.
You unmute. Hello?
Or include for
I think
that.
I'm unmuted.
So yes, at some point for sure, I would say.
I can maybe clarify
Does that answer my question?
So
Her question,
patients
yeah.
with lived experience on could you help me with one question? You're well beyond that. But
Yes,
during the
right.
analysis, for example, as you're coming up with themes, you would meet with them just like you would a research team.
Okay.
Meaning, here's the themes that are emerging because I'm seeing this, and they might say, well, actually, this is not about being shy. This is about being humble, or this is about this. You know, so consider. So they would help.
So
sort
they
of,
become my second
they
people.
wouldn't do
interesting.
necessarily,
Yeah.
they could, do the whole thing, but they
a
would
little
be
bit
like
of-
a co-investigator, reviewing things as they progress with you, giving you ideas.
That's a really
But,
neat idea.
Wouldn't that be
Yes.
fraught with, if you're trying to have the data come forward and you're working hard to not let your own biases affect how you see them, right? I mean, I think it's very powerful that you personally have not had a miscarriage and are studying this, because I think that anybody else who has had a miscarriage would have that experience contaminate what they get from the data somehow. And I just wonder if that, you know.
I'll encourage
That
you to
often
speak
happens.
with
That often happens
with
in
Claire's
qualitative
team, and
Yeah.
they can probably.
Yeah. Do you want, I feel bad because I know there's people there, but there's just
That's okay,
too. I'm
yeah.
sorry.
Oh,
Yeah.
sorry.
No.
I just wanted to build on Doug's point a bit. I
Yeah.
work for Dr. Liddy.
Oh,
And
okay.
I don't know if you're familiar with the eConsult program.
Yes, I am.
Yeah.
Yes.
So
Yeah.
basically.
As a clinician, yeah.
Oh, yeah.
Yeah.
So we've done several studies actually looking at qualitative analysis of the survey responses. That
Okay.
sort of question 5, give us any feedback that we've done. So we've
Yeah.
actually had some experience doing qualitative work
Okay.
on surveys, and it's been well received. It's been published, so it's definitely
Great.
doable. And we followed, obviously we use Doug as a resource, so we followed a lot of his advice, but it might be worth looking at in
Okay.
terms of methodology and how it's
Perfect.
structured, because
Okay.
it's like more charted ground on the
Yes.
kind of
Got it. Okay.
methodology.
That's great.
The chat is starting to heat up, so
Oh, really? Will I be able to access that later? I'm so curious.
I can definitely get these to you.
Okay.
Yes. So Dr. Lise Bruyère is just saying that McGill University Department of Epidemiology used to have a strong qualitative research team under Dr. Abby Littman, and there may still be some courses or resources that could be useful in supporting and informing sort of
I looked at their summer
Your,
institute, so yeah.
your
okay.
methodology, yeah.
Yeah.
Oh, late, Dr.
Oh, okay.
I was gonna see maybe because Dr. Liddy tried a couple times to connect the
Hi there, I'll try to
microphone. I was
share.
gonna see if we can
I'll try to
potentially
share.
see
Can
if
you hear
it
me?
works. We've never tested this before.
These are my kids, by the way, if you're wondering.
Yeah.
These random.
Yeah.
That's
So
thank
the
you so much for that.
Dr.
the
Liddy, can you
qualitative analysis piece of it, including patients in it,
Yeah,
it is very
go
much
for it.
as
Quickly, actually,
Simone
you don't
said.
even-
It really is expanding your research team, but you can choose where you're going to do it in the study. So really, you're doing a first pass. As Doug suggested, to strengthen the trustworthiness of your analysis, you should include at least one more person at some point, and then you may do a third analysis, which would have patients with lived experience in it. They definitely bring a bias in, as all of us do. So it would just be a matter of the acknowledgement of the bias. So it would could be very interesting, and just as another additional option to enrich your results.
Okay, that's great. Thank you so much.
Do you have anybody else?
Nope, I think.
I've seen so many things pop up.
No, I'm also chatting with them as well, so it's yeah.
Okay.
Yes. Thank you, Dr. Lee. Anybody else?
Great. Thank you all for making
Thank
it
you,
here.
Sarah.
I can't believe
We resume at?
What time is it now? It's 9:32.
9:35.
Yeah, that's at 9:30.
Perfect.
There you go. Perfect. Thank you so much.
9:35, there we go.
Yeah.
That's 5 minutes.
Yeah. No, and that worked beautifully. Yeah, that's great. Good job.
It's been busy for a number of years.
Yeah.